Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 346 of our pharmacotherapy entitled Dosing of Drugs in Renal Failure. The first case reads, GGK, a 31-year-old, 70-kilogram woman with a 3-year history of systemic lupus erythematosus, presents to the emergency department with a 5-day history of fatigue, weakness, and nausea, as well as worsening of her facial rash and a fever of 40 degrees Celsius. Her systemic lupus erythematosus had been moderately controlled until this acute flare. Her admission laboratory workup now reveals the following pertinent values. Potassium levels of 6.0 milliequivalents per liter. Sodium levels of 142 milliequivalents per liter. Serum creatinine of 3.4 milligrams per deciliter. And a blood urea nitrogen of 38 milligrams per deciliter. Complete blood count reveals a hematocrit of 32% and a hemoglobin of 9.2 grams per deciliter. The platelet count is 50,000 per microliter, and her erythrocyte sedimentation rate is 35 mm per hour. Physical examination is significant for a blood pressure of 136 systolic, 92 diastolic and 2+ pedal edema. Prednisone is started at a dose of 1.5 mg per kilogram per day. During her hospital course, GGK's condition worsens and signs of sepsis develop. Pseudomonas aeruginosa is cultured from her urine. Therapy with ceftazidime is initiated at a dose of 2 grams every 8 hours, a dose commonly used for patients with normal renal function. Considering that GGK's renal function has remained stable and that she has an estimated creatinine clearance of 27 milliliters per minute, what factors should be considered before modifying her dose? What would be an appropriate dose of ceftazidime for GGK? Before modifying the dose of any drug, its route of elimination should be established. As a general rule, the degree to which renal impairment affects elimination depends on the percentage of unchanged drug that is excreted by the kidney. Thus, the elimination of most drugs that are primarily cleared by the kidneys will be decreased in the setting of renal impairment. For many drugs dependent on the kidney for elimination, relationships between some measurement of renal function, e.g., creatinine clearance, and some parameter of drug elimination, e.g., plasma clearance or half-life, have been established to help clinicians determine the appropriate dosing modifications in patients with renal disease. In contrast, the clearance of drugs that are eliminated primarily by non-renal mechanisms, e.g., hepatic metabolism, is not altered significantly in patients with renal disease. However, Some drugs have water-soluble metabolites that have either pharmacologic activity or potential toxicity and that may accumulate with renal dysfunction, warranting dosage adjustment or avoidance of the drug entirely, e.g., meperidine. Enzymes with metabolic capacity have also been found within renal tissue, which can result in the kidneys playing a limited role in the metabolism of certain drugs. The clinical importance of this elimination pathway is unclear. Another important factor to consider is the therapeutic window for a given drug, i.e., the range of drug concentrations thought to be most effective. Drug concentrations below this range are usually subtherapeutic, whereas concentrations above this range can lead to a greater incidence of adverse effects. For drugs with a wide therapeutic window, the difference between toxic and therapeutic concentrations is large. Although many drugs that are cleared primarily by the kidney may require dosing modifications in patients with renal dysfunction, aggressive dose reduction may not be necessary for drugs with a large therapeutic window, particularly if the adverse effects of the drug, e.g., fluconazole, are relatively mild. This is in contrast to drugs, e.g., aminoglycosides, vancomycin, or foscarnet, that are eliminated primarily by the kidney and have narrow therapeutic windows. For these drugs, the toxic plasma concentrations are very close to the therapeutic drug concentrations, with little room for dosing error. Ceftazidime is a cephalosporin that has excellent activity against most strains of Pseudomonas species. As with most cephalosporins, ceftazidime primarily is cleared by the kidneys, with little nonrenal or hepatic elimination. The correlation between the clearance of ceftazidime and creatinine clearance in milliliters per minute is represented by the equation. The clearance of ceftazidime in milliliters per minute is equal to 0.95 multiplied by the patient's creatinine clearance plus 6.59. Using equation above, the clearance of ceftazidime in patient GGK is estimated to be 32 ml per minute compared with an average normal clearance of approximately 100 ml per minute. Because her drug clearance is approximately one-third of normal, she would require about one-third of the normal daily dose, i.e., 2 grams every 24 hours. As with other cephalosporins, ceftazidime has a large therapeutic window. Failure to reduce the dose from a normal dose of 2 grams every 8 hours, although likely safe, might lead to accumulation of ceftazidime, predisposing patient GGK to seizures and other adverse effects associated with toxic beta-lactam antibiotic plasma levels. This is in contrast to the aminoglycosides, which must be dosed based on specific pharmacokinetic calculations. Therefore, more generalized or empirical dosage modifications can be made with ceftazidime. My next question to you reads, patient GGK's medical team decides that the addition of an aminoglycoside antibiotic is necessary to treat her infection. Considering that her renal function has remained stable, how should gentamicin be dosed in patient GGK? Is it best to alter the dose or the dosing interval for this drug? Let's begin by discussing alteration of dose versus dosing interval. The aminoglycosides, e.g., tobramycin, gentamicin, or amikacin, are effective in the treatment of serious systemic infections caused by gram-negative organisms such as Pseudomonas species. Unlike the cephalosporins and penicillins, however, the aminoglycosides have a relatively narrow therapeutic window. Using pharmacokinetic principles, a dose regimen can be designed to produce specific peak and trough serum concentrations. Peak serum concentrations, abbreviated as CP peak, e.g., gentamicin or tobramycin 5 to 8 mg per liter, correlate best with therapeutic efficacy, whereas toxicity tends to correlate with elevated trough levels, abbreviated as CP trough, which reflects prolonged exposure to high drug concentrations. To minimize the risk of toxicity, trough levels of less than 2 mg per liter should be maintained. In patients with normal renal function, these target serum aminoglycoside concentrations are usually obtained after standard doses, e.g., 1.5 mg per kilogram, administered every 8 hours. Peak and trough levels are typically measured once steady state is achieved, which is typically within 24 hours. Many clinicians now use once-daily dosing of the aminoglycosides, e.g., 5 mg per kilogram every 24 hours, for patients with normal renal function in an attempt to minimize aminoglycoside accumulation and nephrotoxicity. The rationale for this regimen is based on the aminoglycosides concentration-dependent killing and post-antibiotic effect. This approach is not recommended for patients with advanced renal impairment, however. When once-daily dosing is used, peak concentrations are less helpful. However, trough concentrations should be monitored with a target of being below the limit of analytic detection, that is below 1 mg per liter. The discussion regarding aminoglycoside dosing in renal impairment that follows is based on the traditional every 8 hours dosing regimen. Aminoglycosides are almost completely eliminated by the kidneys. Thus, the clearance of these drugs essentially is equal to the glomerular filtration rate. The pharmacokinetic properties of gentamicin and tobramycin are similar. A close correlation also exists between CrCl, a surrogate for glomerular filtration rate, and gentamicin total body clearance. As renal function deteriorates, aminoglycoside doses must be modified to achieve the desired peak and trough plasma concentrations. Failure to appropriately adjust the dosage of aminoglycosides in renal insufficiency can lead to high drug plasma levels that can result in ototoxicity and nephrotoxicity. In many cases, the aminoglycoside dose can be modified by extending the dosing interval rather than simply reducing the dose. This permits maintenance of adequate peak plasma concentrations to ensure efficacy, while allowing for sufficient elimination between doses to produce trough levels less than 2 mg per liter. With renal function that is 30% of normal. Although this is the preferred method for adjusting the dose of aminoglycosides, for many other drugs requiring dose adjustments in renal disease, simple dosage reduction is sufficient. Commonly used drug references such as facts and comparisons can be used for dosing guidelines for drugs used in patients with renal failure. Let's now look at determination of appropriate dose. A number of methods have been developed to determine the appropriate aminoglycoside dose for patients. One method is Bayesian forecasting, in which pharmacokinetic data obtained in the individual patient are integrated with population parameters. Initially, a dose is used that is based on population parameter values adjusted for characteristics such as increased serum creatinine. Drug concentrations for the individual patient are measured at specific times, e.g., peak and trough measurements, and these are compared with the expected values from the population data. Individualized pharmacokinetic parameter estimates are subsequently derived using Bayes' theorem to calculate a more patient-specific dosing regimen. Because of the wide interpatient variability in aminoglycoside pharmacokinetic parameters and the narrow therapeutic index for these drugs, doses should be adjusted based on pharmacokinetic principles and plasma concentrations that are specific for this patient. We will now look at patient-specific methods. Sorchak and colleagues developed a method to derive patient-specific estimates of volume of distribution and clearance based on the patient's size and estimated creatinine clearance. These parameters can be used to calculate a specific dose for GGK that will produce the desired gentamicin peak and trough concentrations. If steady-state serum concentrations of gentamicin are known, they can be used to calculate even more specific parameters. To initiate gentamicin therapy, pharmacokinetic parameters should first be estimated from population values. The clearance of gentamicin, abbreviated as CL-gent, can be calculated based on GGK's creatinine clearance. Using the Cockcroft-Gault equation, the creatinine clearance can be estimated as follows. Creatinine clearance for males is equal to 140 minus the age, multiplied by ideal body weight, all divided by the serum creatinine times 72. Creatinine clearance for females is equal to 140 minus the age, multiplied by ideal body weight, all divided by the serum creatinine times 72, all multiplied by 0.85. Where IBW is ideal body weight in kilograms, age is measured in years, and serum creatinine is measured in milligram per deciliter. With a serum creatinine of 3.4 milligrams per deciliter, an ideal body weight of 70 kilograms, and an age of 31 years, GGK's estimated creatinine clearance is 27 milliliters per minute. For practical purposes, CL-gent is usually considered equivalent to creatinine clearance. Therefore, CL-gent also is approximately 27 milliliters per minute or 1.6 liters per hour. The volume of distribution of gentamicin, abbreviated as VD-gent, is approximately 0.25 liters per kilogram in patients with normal or impaired renal function. The volume of distribution of gentamicin will be different in obese patients or those who have fluid overload. Although GGK does have some fluid retention, this is minimal and should not affect her volume of distribution of gentamicin significantly. Therefore, the volume of distribution of gentamicin for GGK is as follows: VD-gent is equal to 0.25 liters per kilogram, multiplied by the patient's body weight, which is equal to 0.25 liters per kilogram multiplied by 70 kilogram, which is equal to 17.5 liters. The loading dose of gentamicin, abbreviated as LD-gent, can be determined using the following equation. LD-gent is equal to the volume of distribution of gentamicin multiplied by the desired peak concentration, abbreviated as C-peak. For treatment of infections caused by Pseudomonas species, a peak level of the loading dose of gentamicin is equal to 17.5 liters multiplied by 7 milligrams per liter, which is equal to 122.5 milligrams. We can round this off to 120 milligrams. Using CL-gent and VD-gent, the elimination rate constant, abbreviated as KD, and half-life for gentamicin can be estimated to be 0.091 per hour and 7.6 hours respectively. For the aminoglycosides, the dosing interval is determined by doubling the half-life, because by the end of 2 half-lives, 75% of the drug will have been eliminated. This will usually lead to a desired trough level of less than 2 milligrams per liter. Therefore, gentamicin should be administered at least every 16 hours. For convenience, an interval of 24 hours can be used, which also will achieve the desired trough concentration. Gentamicin is usually infused over 30 minutes. To determine the peak gentamicin concentration, serum samples are drawn 30 minutes after the infusion has been completed. Because the estimated elimination half-life of gentamicin in GGK, which is 7.6 hours, is much longer than the infusion time, which is half an hour, the intravenous IV bolus model can be used to calculate an appropriate maintenance dose. To achieve the peak concentration of 7 mg per liter, the following equation can be used, yielding a dose of 119.2 mg, which can be rounded off to 120 mg. Assuming T sample usually equals 1 hour. That is 30 minutes after a 30-minute infusion. The expected trough level in GGK can now be estimated by the relevant equation, yielding an expected trough concentration of 0.8 mg per liter. Although not the case for GGK, patients with normal renal function may eliminate a significant amount of gentamicin during the 30-minute infusion. In these patients, the intermittent infusion model should be used to account for this loss of drug, where T-in is the duration of the infusion according to the relevant formula. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 347.